Hi, I'm Mark Keeney. I'm an associate professor of medicine at Columbia University Medical Center. And today I'm going to talk about the interaction between COVID-19 and myeloproliferative neoplasms. So like many of you, I'm here at home competing with my kids for bandwidth and quiet places in the house and doing my best to make sure that I'm dressed appropriately, at least from the waist up. And I think this has been a brave new world for many of us. So what I'd like to start off by doing is reviewing some of what we know about COVID-19, telling you a little bit about what has happened here in New York, which is really the COVID epicenter in the US, and then talk a little bit more about how COVID-19 might be impacting patients with myeloproliferative neoplasms. So COVID-19 is a disease that's caused by the SARS-CoV-2 virus, and SARS stands for Severe Adult Respiratory Syndrome. I think we've found that this is really not necessarily an appropriate name, because although we expected this to be a disease primarily affecting the respiratory system and affecting adults, we found that it also affects children, and it involves much more than just respiratory system, affecting the GI tract, the kidneys, the central nervous system, and the blood systems. Since I'm recording this on May 5th, and as of this morning, the Johns Hopkins COVID Resource Center reported that we have more than 1 million confirmed cases of COVID-19 in the US, with 69,000 deaths. And thinking more broadly in the world, there are more than 3.5 million confirmed cases, and really a mind-boggling 250,000 deaths, really just mainly since the beginning of 2020. As you can see, demographically, the epicenter is here in the Northeast, where my patients are, and New York City, I think, is the bullseye within the bullseye. But nowhere in the United States has been immune from the effects of COVID-19, and I think there have been cases and deaths in every state in the US and in many, many countries throughout the world. The disease, though, has really caused us to have many more questions than answers. And some of the unanswered questions that we have just from some of the epidemiology is, why has COVID-19 impacted some parts of the US and some parts of the world more than others? And some of the explanations for this have included population density. Some have argued that places like New York City, which has one of the highest population densities in the US, is more susceptible just because patients and people are closer together. There's been some suggestion that age distribution has an impact on the disease, since it tends to affect older individuals more than young. And so countries that have a higher proportion of older patients or older people may be more significantly affected. And that's been supported in some ways by the data coming out of Italy, which was really tremendously affected by COVID-19, but other countries that have similar age distributions, like Germany, don't seem to be as severely affected. Some have wondered whether there are differences in the virus. Looking at the virus structure, one of the things about coronaviruses is that they tend to mutate more slowly than influenza virus, for example. That said, there are slight differences in the virus between strains that are predominantly affecting Europe and strains that are predominantly affecting China and Southeast Asia. And on the West Coast, it seems that the virus is more consistent with the strain that's affecting China, and whereas the European strain seems to be predominant on the East Coast and here in the Northeast. Some have also wondered whether there are inherent differences in immunity. People from China and India and Russia are often vaccinated for tuberculosis with the BCG vaccine. And some have wondered whether that has protective effects and may lead to fewer cases and more mild cases than people in the US with BCG and seem to have had much more severe disease course. Questions about why, on an individual basis, some individuals are more affected than others. We know that age can have an effect on severity of disease, and older individuals in particular seem to be more susceptible. Also know that individuals in the prime of life and children have also died from coronavirus. So age by itself is not the only explanation. Underlying diseases also may play a role, although there have been some surprises there. And hypertension, for example, seems like it's a much more of a risk factor than asthma. And we would have expected respiratory compromise to be something that led to much more severe COVID-19 infection. And for healthcare workers, we wonder whether some young healthcare workers have died from the disease because of the amount of exposure they had to individuals in the emergency room. And it may be that the dose of virus that an individual is exposed to may play a role in severity. For my patients with myeloproliferative disorders, there are other questions that we don't know the answer to. We don't know whether the type of the myeloproliferative neoplasm has an effect on susceptibility or severity of COVID-19. We wonder whether the different treatments that we use for MPNs may affect the ultimate risk of the disease, including phlebotomy, medications like hydroxyurea, interferon, which is a substance the body ordinarily makes as a response to viral infection, or whether the JAK2 inhibitors like ruxolitinib and fedratinib and other investigational medicines might impact the risk or severity of COVID-19. Here in New York, COVID-19 has really had an incredible impact. In the state of New York, there have been nearly 325,000 cases and 25,000 deaths. And the case fatality rate in the state is about 7.7% using those figures. New York City has really borne the brunt of both infections and deaths. And you can see that with 181,000 cases and 18,000 deaths, we've really had a disproportionate number of deaths in the city, and the case fatality rate, at least using these figures, is 10.3%. Now, fortunately, I think we're now on the downside of both infections and deaths. Our hospital is slowly declining in the COVID population, and the New York State and New York City numbers have shown a fairly steady decline over the past couple of weeks. At the same time, there's evidence that COVID infection has been much more widespread than just the positive COVID virus tests would indicate. last week, there was more broad antibody testing, which should assess whether or not someone's been exposed to the virus. And that's found that about 25% of New York City residents had antibodies to the virus. The incidence of infection seems a little bit less here in the suburbs, and in upstate portions of New York, it seems like the incidence is dramatically less, with about 3%. And so using these numbers, the case fatality rate of COVID seems to be substantially lower, closer to 1% than 10%, just using the positive virus testing. These figures, though, are still very challenging to interpret. In the beginning of the epidemic, I think everyone would agree that the availability of testing was really much more limited than it should have been. We still have patients who are in the ICU and have been in the ICU for weeks on ventilators. And, unfortunately, those patients have uncertain futures. And it's possible that that may have an impact on the fatality rate, even after the incidence of infection seems to be dramatically lower. And we still have some question about the testing accuracy. I know a number of individuals who tested negative on multiple occasions for virus exposure, and but a week later, when the antibody test was available, were found to have evidence of infection with the antibody test. There are many different antibody tests available. I think only one has been FDA approved as of today. And so it's very hard to know and have confidence in the testing results. And so we're really still challenged by the data that's available to us. In New York, all of the hospitals in New York, including the great academic medical centers and teaching hospitals like Columbia, were turned into COVID hospitals, and all of the resources of the hospital, plus spots in Central Park, in our convention center, were devoted to taking care of patients with COVID-19. Elective surgical and medical procedures were deferred, and some of that was done to reduce the risk of patients with COVID-19 in the hospital, infecting people from outside the hospital who weren't infected, and the other way around, people from the community who had COVID-19 infection coming into the hospital, infecting patients who didn't have COVID-19. Every nook and cranny in our hospital was used for clinical space, and operating rooms that weren't used for elective procedures were repurposed to become ICUs. All of the laboratory research was mothballed, and really only enough research to keep things going at the lowest possible levels were continued, mainly to reduce the risk of infection by laboratory personnel one to another. And in addition, all clinical trials were really frozen. Although patients who were already enrolled in clinical trials were continued and supported, patients who may have been eligible for clinical trials were told to stay away, and we were conducting trial visits remotely as much as possible. The good news now is that although our resources were really challenged and the system bent, it didn't break, and so we weren't overwhelmed the way some hospitals in Europe were. And now there are active plans to normalize operations, but we understand that there's really going to be a new normal. And that new normal is going to involve frequent testing of patients and staff, ongoing strategies that are designed to minimize hospital and clinic-acquired infections, and hopefully new strategies to manage active infections. And what we've learned so far is that COVID-19 really has a distinct pathology. We know that there are direct effects of the virus on lung and GI tissue, but there are also indirect effects. And COVID-19 dramatically activates the inflammatory and immune pathways. And this can cause adult respiratory disease or distress syndrome. It activates coagulation, causing both bleeding and clotting. There are effects on the kidney, the heart, and central nervous systems. And it has effects on immunity. And we've seen really marked declines in some of the white blood cell subsets like the lymphocytes. And as part of this, we found early on that the effects on the kidney really challenged our ability to provide dialysis for a period of time. And so there have been some unanticipated challenges. And we've also learned that patients who seem to be recovering can have sudden deterioration, which is also unusual in many viral infections. So for someone like me who has primary interests in myeloproliferative neoplasms, one of the things that struck me was some overlap between COVID-19 and the effects of disease in patients with MPNs. Both diseases seem to have an important role for inflammatory processes. And for patients with myelofibrosis in particular, inflammation plays a large role in the disease. And we know that all patients with MPNs have abnormal coagulation, and that's also a prominent effect in COVID-19, although we think that the mechanisms are really distinct between the two processes. And so just to illustrate the overlap a little bit more, both SARS-CoV-2 and myelofibrosis have a major inflammatory process that leads to a downstream immune response with upregulation of important cytokines and inflammatory mediators like interleukin-6, hepcidin, interferons, and tumor necrosis factor. And then downstream of that inflammatory immune response, there's target organ damage on the liver, the kidneys, the gut, the heart, and the bone marrow. And so in the myeloproliferative neoplasms, the inflammatory signals come from activation of the JAK protein, and JAK plays a major role in transmitting inflammatory signals into the cells of the body. And although we know that patients with myeloproliferative neoplasms often have activating mutations in the JAK2 protein, even patients with other mutations like MPL and calreticulin or CalR mutations also feed into the JAK system and also feed into upregulation of important signaling for immune activity and inflammation. In myelofibrosis and in some patients with polycythemia vera, we target JAK2 and tamp down that system with drugs like fedratinib and ruxolitinib, and that blocks that process. And so that's led many to wonder whether JAK inhibitors used to treat the myeloproliferative neoplasms might also be effective in COVID-19. And in fact, I've seen clinical trials for just about all of the JAK inhibitors that are FDA approved and in active investigation, now being brought out for clinical trials in COVID-19. And I think we're hoping that what we've learned in treating myeloproliferative neoplasm patients may yield fruit also in treating COVID-19. So getting back to my patients with myeloproliferative neoplasms, I'm a worrier, and I always worry about the effects of COVID-19 on my patients. But so far, those effects have mainly been theoretical. We know that some patients with myelofibrosis are immunocompromised, and so I'm concerned that they could be more susceptible to infection than patients without myelofibrosis. And we also worry about the intersection between the COVID-19 coagulopathy and the MPN coagulopathy, and whether those two processes could be worse. Right now, 8 weeks into the epidemic, unfortunately, most of my patients with MPNs are doing well, and even those who had COVID-19 infection. And I wish I could say that those patients who've had other leukemias have fared as well. But fortunately, patients with MPNs seem to be doing better than patients with other blood cancers. But I think we'll need some data from registries in order to answer some of these questions. And some of that is because the MPNs are really still rare diseases. And so it's going to take a while and many events to see disease-specific trends. And we'll have to work hard to look at that. And the other challenge is that our knowledge of COVID-19 is really being accumulated in real time. We're now 7 or 8 weeks into this epidemic. We wonder whether there will be a second wave of infection. And earlier I mentioned that about 25% of New Yorkers, we think, have been infected. And in some ways, that's a much higher number than we expected just based on the hospitalization data. But it also means that 75% of the population is still naive to the virus and is at risk for infection. And so we don't know what will happen if there's a second wave. And if 3 times as many individuals are infected, will we end up in a scenario that does overwhelm the medical system? We're hoping that treatments like remdesivir, which was recently granted emergency approval by the FDA, will have an impact on the virus. But we don't know how remdesivir will affect patients with MPNs, or whether there might be an interaction with some of the drugs that we use to treat MPNs. We're hoping that the antibody data indicates that there is at least a pool of individuals who are immune to COVID-19, but we don't know yet whether those antibodies are really protective or how long that protection will last, and whether immunity to the New York strain of coronavirus will provide protection to the California strain of coronavirus. And we also wonder whether our MPN patients will be able to achieve the same kind of immunity that patients who don't have MPNs will be able to achieve. And as we move through the year and vaccines are developed, we hope that they're going to be as effective in patients with MPNs as in the general population, but that's something that we still have to learn. So what do I tell my patients with MPNs? What can you do to face the epidemic? I think that my MPN patients, should really make a strong effort to follow the social distancing and hygiene guidelines that are in place, including hand washing, use of face masks, and crowd avoidance. I think that it's important to learn as much about what's going on with COVID-19 in your particular area as possible. I think knowledge is power. I think what's true in New York may not necessarily be true in parts of the country where the virus is less prevalent. And so it's going to be important not to get national knowledge, but also to get local knowledge of what's going on with COVID-19. I think it's maybe important to monitor your temperature. We know that some patients with MPNs can have fever as part of their disease. And so knowing what your fever curve is may help you know when there's a disturbance in that curve. I think it's important to continue to be in touch with your doctor. I think that many patients with MPNs recognize that their diseases are chronic diseases, and so may not necessarily have the acuity of some other blood cancers. But at the same time, I think it's important not to ignore your MPN. Pushing back phlebotomy for some period of time may be okay and may be the right thing to do in terms of some risk-benefit scenarios. But we also know that as the hemoglobin goes up for patients with polycythemia vera, there's also an increased risk of clot. And I had one patient who had symptoms that were almost identical to COVID-19. And fortunately, she didn't have any of the respiratory symptoms, but had the fever and the fatigue. And so we told her to shelter in place and to stay away from the hospital. But the symptoms persisted for a week. And then after a lot of discussion, she came in and we found out that it was really the MPN that was acting up and that the fatigue was due to anemia and the fever was probably due to the MPN. And so she turned out not to have COVID-19 infection and has benefited from transfusion. And so I think we all have to be careful not to assume that symptoms of COVID-19 and MPNs that overlap are automatically due to COVID-19. I think that if you do go into an emergency room or encounter health professionals, you want to make sure that you tell them about your MPN diagnosis so that they understand the full scope of what's going on with you. And as testing rolls out, I think we all have to be aware that there are false positive and false negative results. And so we don't necessarily fully commit to a range of symptoms being definitely due to the virus when they might be due to the underlying MPN. And so in conclusion, I just want to thank Anne Brazeau and the MPN Advocacy and Education International who helped support filming of this video. I'd like to thank my colleagues at Columbia and New York Presbyterian Hospital, many of whom were on the front lines in the emergency room and ICUs while I was taking care of patients who were admitted to the hospital. And finally, I'd like to thank my patients who are really weathering the storm with as much or more uncertainty as I have, and hope that we can all stay strong together. And if you have questions, my email was just on the screen, and I'd be happy to do my best to answer questions that you might have, recognizing that my level of ignorance and uncertainty is much higher than I wish it were. Thank you very much.